Is our father of 3D TE, who has been teaching us.
I think can you hear me here? Yes? Yeah, I think it works. That's fine. So before I start, that is my disclosure. We are a reference customer for Philips, so you will see a lot of Philips videos and pictures. So the topic is mitral valve repair, and I'm happy to announce that the third edition from the Perino book has published right now, and mainly the topics of my talk are included in that chapter, which I was honored to write together with my former colleague, Maurice Hogan. So first I want to talk about the surgical principle of repair, and I think it's all over the world the same. In every repair, whether it's in Europe or in India, annuloplasty is used. So that means you need a ring for that. Thank you for the music. And then you can either respect, that means you leave the tissue and use artificial cords, or you resect. The problem with the resection is that you will have at the end less coaptation length, but it's up to now it's equal. I think in India more resection is been done because of the highest incidence of mitral stenosis. But as I learned from the website yesterday, you also offer a lot of mitral repair for people outside India for affordable price, so that means you will also see a lot of patients with prolapse. So what do we have to do in the pre-op echo? Of course, we have to examine the structure of the mitral valve apparatus, the function of the leaflets, the severity. The severity, not to really make a decision if that valve should be repaired. I think that has to be done in the pre-op echo. But to really see how much regurg the patient has now under general anesthesia, and then to compare that after the repair. And then, of course, the predictors of repair failure and identification of some risk factors. And last not least, the localization of the circumflex artery. So these are the recommendations of the American Society from 2017. And of course, first is the imaging of the valve, and then the Doppler examinations. You all know that based on the recommendations from Alain Carpentier, you will judge the mitral valve apparatus or the leaflets by the motion. And we will have primary mitral regurgitation and secondary. So primary means the leaflet or the mitral valve apparatus itself is involved. Type 1 with the normal leaflet motion, type 2 with an excessive motion, type 3 with restrictive motion. And in type 3 we have the 3B, which is secondary mitral regurg. You see the arrow? Yes. So that means the mitral valve apparatus itself is normal, but due to the dilatation of the left ventricle, you have too much tension on the leaflets, which cause restrictive motion on that. You can assess that in 2D and in 3D. Dr. Koshi has really very well explained that. The value of 3D is that everyone looks at the same valve, of course. To be honest, all these studies which compare 2D and 3D, I think they all emphasize 3D. But if you have a good 2D exam, you can nearly be as good as 3D. So the poor results in a lot of studies, in my mind, are based on the poor 2D image quality and not based on the technology itself. And for that, just think of that. If you want to have the 2D images of the mitral valve in the metaesophageal thing, you have to make sure that the left ventricle is in the middle of the picture, of your 2D picture, without foreshortening. And then the only thing you have to do is do rotation and keep the probe still. And then you get all the images, and you can really identify these leaflets also with 2D. But the advantage, as I said, 3D will allow everyone to look at the same picture of the valve, whereas in 2D, everyone has his own 3D mental reconstruction. So here are some examples. That is a type 1 with normal motions. It's a patient with a cleft, which is sometimes very difficult to identify in 2D. There, the basal short axis view helps a lot because the cleft is seen in diastole, as you see here on the right upper. In 3D, of course, it's not a problem to identify that. Then you have the type 2, excessive motion. Remember, prolapse is defined as the free margin of the leaflet directed, this one, to the left ventricle, whereas a flail, or that is a bollow, sorry, so where you have a billowing of the body of the leaflets. And if it's as excessive as in that patient, it's a billowing of all the segments. See that here. And then you have a type 3A, a restrictive motion, so structural, which you will see mainly in your patient population, of course. You see that is the picture of one female created at one of the Bangalore workshops 10 years ago. So that was really nice. You see the funnel-shaped one. And then you have the 3B, restrictive motion, as I said, due to the ventricular enlargement, either by dilated cardiomyopathy or by coronary artery disease, where you see a restrictive motion either of both leaflets or mainly on the posterior leaflet, especially on P2 and P3. So the probability of repair depends on the disease, of course, and of the skill of the surgeon. Rheumatic as well as Barlow disease is judged as unlikely, but if you have a good surgeon and if you have a good echocardiographic guidance, you can do a lot in that. So the repair success for type 2, so degenerative, is excellent over the 10 years, so with 90%. You see that? For secondary, mitral regurg is not as good. So you see, over 10 years, 50% gets reoperated or died because reoccurrence of mitral regurg. So nowadays, the tendency is more to replace the valve than to repair the valve in secondary MR. And here you see the results between degenerative and rheumatic. So it's not bad. It's inferior to the degenerative, but it's not bad depending on the center and the surgeon, of course. And here you have the freedom from valve failure. 75% over 10 years, it's not too bad. So coming now to the mitral graduation of the mitral regurg. As I said in the beginning of my talk, you have to have in mind that general anesthesia will have a huge impact on your mitral regurg. So you have to either use volume or norepinephrine to counteract the consequences of anesthesia. And here is the grading published from the European Society 2013, where you have qualitative, semi-quantitative, and quantitative measurements, ROR and all that. And these are the guidelines of the American Society, published 2 years ago, and you can see there's no difference in these guidelines. So it's still all these parameters, which I think you know already. So one of the qualitative things is the density of the continuous wave Doppler signal. The more dense and the more triangular the regurgitation jet is, the more pronounced is the mitral regurgitation. It's just due to the amount of erythrocytes which pass through the mitral valve in systole. That's it. And now but have in mind that AFib, for example, you see, will give you all of the densities. So we're really very dense here and not so much dense here. So you have to look in patients with AFib to a lot of heartbeats to really use that. I think a measurement which is very simple to do, especially also for post-op, is pulmonary venous inflow, because that will really immediately change after a mitral valve repair, and you don't need so much skills for that. You know that normal systolic wave is more than diastolic, and in severe MR you will have a reversal. In eccentric flows, you should use the left upper and the right upper pulmonary vein, of course. Be sure that you have the correct machine settings. So whenever you use color flow, You have to adjust your color gain. You have to adjust the Nyquist limit. And all the measurements are based on a Nyquist limit between 50 and 70, except PISA. Because in the PISA formula, the Nyquist limit is included. And you see also the transducer frequency will have an impact on your color flow appearance on the machine. And the next thing is the timing of the MR jet, because it depends on the disease, if it's and the gradation, if it's holosystolic, late systolic, or early systolic. And that is for vena contracta, for PISA, and for 3D vena contracta area, so for all of that. So if you look then, please look where is your main mitral regurgitation jet. First you do the 2D, and then you add the color, and then you see here with X-plane you can really scan through all the leaflets, and then you have the 3D color here, which shows you all that in one picture. 3D quantification, you can use vena contracta area, that was pointed out by Dr. Koshy very well, so you can use multi-planar reconstruction for that. But again, if you want to use that, so up to now, 3D vena contracta area is not mentioned in guidelines, except for the new guidelines published January this year for transcatheter mitral valve repair, but it's not recommended in the guidelines up to now. But look that if you do that vena contracta area throughout the systolic cycle, you will have in secondary MR, early and late systolic, the greatest area. In primary MR, you will have it more late systolic or mid systolic. So if you would want to use vena contracta area, you should measure a lot of vena contracta areas and then do the average, which no one will do in clinical practice, I think. So, but if you just measure in one cycle, you see that here you can underestimate the primary MR with 3D vena contracta area. What else can you measure? A lot. So that was published by Feroz, and hopefully if you want to do all these measurements, you can use software, special software, which gives you all these numbers here, which are more or less validated depending on the quality of your image. What we do on measurements is, because the annuloplasty ring is sized by the surgeon with the intertrigonal distance and the length of the anterior mitral leaflet in cardioplegic arrested heart. What we do, we measure both these dimensions, of course. So the annulus diameter, you can do that. The mitral commissural view gives you a rough impression how the intertrigonal distance is, but it is not the intertrigonal distance. Then you measure the length of the leaflets, of course, the C-sept distance, and the diameter in left ventricular diastolic, the length of the left ventricle, and the tenting area in the secondary one, and the tenting height, of course, also in the secondary MR, because a tenting height of more than 1.2 centimeters, then it's unlikely that mitral repair in secondary MR patients will last long. Then you can identify risk factors for SEM. So by measuring C-sept, C-sept is the most predictive factor. A C-sept measured in the long axis view, metaesophageal long axis view, or as depicted here by Maslow in the 5-chamber view, a C-sept less than 25 millimeters is the highest predictor for SEM after mitral repair. Then you measure the left ventricular internal diameter in diastole, another predictor. Then the posterior mitral leaflet length, above 15, also a predictor for SEM. The basal septal diameter, if it's hypertrophied, it will be a predictor for SEM, and the automitral angle, which you can measure with special software. Below 120 degrees is also a risk factor for SEM. So you see SEM here. The anterior mitral leaflet is pushed in the LVOT, resulting in a large MR. You can, of course, measure all these things with multi-planar reformatting using 3D, which may be more accurate if the frame rate is high. And then that is at least what we do, hopefully, and I will encourage you to do that the same. Circumflex artery, to visualize that, because in 2 to 4% of the mitral replacement or the repair, the circumflex artery is compromised. And how you do that, you see that here, that is Rajni Singh, one of our senior consultants. It's easy from the long axis, mitral long axis view. You just rotate, look at the hand here. You just rotate the probe slowly to the left at 110 degrees. And then you follow the course of the circumflex here very easily. You can download that video also from Anesthesia and Analgesia. So, and then the required measurements, at least from our most experienced surgeons, is what is the distance of the circumflex to the mitral annulus, and for that you need 3D, and then you can measure the distance, and also the level of the circumflex related to the mitral annulus, and these are the two numbers what they want. So then you have the post-op repair, of course, and in post-op repair evaluation, you localize and quantify residual MR, which is sometimes not really very easy. Examine for stenosis, of course, and screen for potential complications. And the first screening is immediately after release of the cross clamp, because at that time, the left ventricle is unloaded, and you have full flow to the coronaries due to the cardiopulmonary bypass. And you see, if you use CaliFlow here, you see really in every patient, the circumflex artery and the flow. So that means in that situation, you can immediately identify if there's a problem with circumflex, and the surgeon can immediately go second time for cross clamp and fix that problem. So then during bypass, you look, during weaning, you look for air, especially for minimally invasive mitral valve repair. De-airing is a problem. You see here a lot of air, and unfortunately all that air goes into the right coronary ostium, as you know, so that may cause regional wall motion abnormalities. So look at that. And really, that air, at least in Germany, it's not just immediately if the heart is unloaded. It's really during weaning. So the more the right heart ejects, the more bubbles will come there. And I think every one of you have experienced those patients who end up with ventricular fibrillation during transfer from the OR to the ICU, and no one knows what is the cause. Look really very carefully of de-airing, because in a lot of patients, it's air which is mobilized just by putting the patient from the OR table to the bed, and then the air gets mobilized. So we try to get all that air out before we send the patient to the PACU or to the intensive care ward. So post-bypass evaluation of the residual MR, it can be tricky. So in that specific case, the identification, the localization is really much more easier done by 3D using color and by using that vena contracta area, although I mentioned that it's just in the guidelines for transcatheter mitral repair, but I don't see any reasons why it should not work also for surgical MR. So that you really measure each vena contracta area and you add the vena contracta area in 3D, which is a little bit time consuming, but it's feasible also in the OR. Then as a result, you measure the coaptation length of both leaflets. That you do in the mitral long axis view. And you should aim for a coaptation length of more than 5 millimeters. So with the resection, you will get between 5 and 7. Using artificial loops, you will easily go from 7 to 11 millimeters coaptation length. And then having the annuloplasty ring will mean that it's unlikely that that patient will get another MR. You use continuous wave Doppler, of course, for measuring if there's a stenosis, or you do a planimetry of 3D. Remember that the color Doppler, the continuous wave Doppler is dependent on heart rate. So you will overestimate the gradient if the heart rate is above 80. And so you have to look at that. Then scan for complications. So that is a regional wall motion abnormality, which occurred, of course. And it's because of circumflex occlusion. You see that here. which was certified with angio. That is, you see that? That is SAM, of course, which occurred after that. You see the thick septum here. And then a new onset of aortic regurgitation could be a problem by fixing especially the right coronary cusp with one of the sutures. So the predictors, to conclude, is surgical expertise, the disease pattern, the patient population, and of course correct echocardiographic guidance of you guys. So, and I hope to see you next year in Leipzig, where we will have the ACTA echo. Thank you so much.